Good afternoon to everyone. My name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome you to our webinar series entitled Medical and Public Health Considerations of COVID-19. This specific webinar is a collaboration between ACMT and the PACU, which is part of a mini-series on safer disinfectant use in COVID-19. And the title of the webinar today is Toxicity of Chemical Disinfectants Encountered in Everyday Life. Next slide. And this webinar was supported by the American Academy of Pediatrics and funded in part by the Cooperative Agreement Award with the AAP and the Agency for Toxic Substances and Disease Registry. ATSDR does not endorse the purchase of any commercial products or services mentioned in the PACU publications. Next slide. I'd like to thank our webinar series partners for helping to get out the word about the webinar series. Very much appreciate their support. Next slide. So as mentioned, this webinar is part of a mini webinar series within our larger COVID response webinar series that we've been holding since March of 2020. This is actually the 37th webinar in a mostly weekly series of webinars. And this is the second in a series of 6 webinars specifically designed to address the issue of safer disinfectant use. Next slide. The first webinar we held in December, that was a disinfection and sterilization of primer with a focus on use in healthcare facilities. And continuing this series in the spring, we'll have a disinfectant webinar about special populations, that will address issues in the reproductive, breastfeeding, and at-risk groups. And we'll also have another webinar on hand sanitizers, and several additional webinars will be developed over the summer and fall. Next slide. We're developing a series of resources to accompany this webinar series up on the ACMT website. As you can see there, we've frequently asked questions about our first webinar, and with each of the webinars, we develop a series of additional FAQs for your to be used as a resource. Next slide. This webinar will have a Q&A at the end of the webinar. The Q&A often will go for 15 or 20 minutes. We really encourage folks to write in their questions. If you could put it into the Q&A function during the webinar, we'll try to get to as many of the questions as possible. If any of you are on the simulcast on YouTube, please put the questions into the chat. Next slide. I'd like to thank my co-moderator and also one of our featured speakers today, Dr. Ziad Kazzi. He's a board member of ACMT and president of the Middle Eastern and North African Clinical Toxicology Association. He's associate professor of the Department of Emergency Medicine at Emory University, and he'll be one of the speakers today. Next slide. We've developed this webinar actually with a full panel of speakers, and additional speakers will include Dr. Charles McKay, who's past president of ACMT. He's the associate medical director of the Connecticut Poison Control Center and a clinical professor at the University of Connecticut. Dr. Ashley Haynes is the medical director of Holland's Pathways and is a volunteer faculty at the University of Kansas School of Medicine. And Dr. Timur Durrani is associate clinical professor of the School of Medicine at the University of California, San Francisco. And he's the past medical director of the PACU Region 9 and serves as a consultant to the PACU program currently. Next slide. Our speakers do not have any conflicts of interest to disclose. Next slide. So the learning objectives for today's webinar are the following 3 points. Understand the different types of EPA-approved disinfectants for COVID-19. Describe the acute toxicity of inappropriate use of quaternary ammonium compounds, bleach, and hydrogen peroxide. And to discuss the potential health effects of repeated exposure to commonly used disinfectants in schools and healthcare facilities. Next slide. This is some data from the Poison Control Network that came out early on in the COVID pandemic and the end of the first quarter of 2020. And just goes to show you the rapid increase in the number of calls to poison control centers involving both cleaners and disinfectants. So with COVID hitting us all and an increased use of disinfectants and other cleaners, the number of calls to poison control centers regarding possible toxic events is demonstrated in this data set. Next slide. So what are some of the properties of an ideal disinfectant? This is the one slide we continued from the first webinar that was given by Dr. David Weber. Ideal properties include the fact that they should be broad spectrum, fast acting, remain wet, not affected by environmental factors, non-toxic, ideally, surface compatibility, persistent, and easy to use. So these are some of the core properties of an ideal disinfectant. Next slide. So our approach to disinfectant includes some basic terminology at the outset. Chemicals used to disinfect are often divided into antiseptics, which are slightly different, and the disinfectants. And something to keep in mind is that the typical antiseptic is a chemical that's applied to living tissue, while a disinfectant is a chemical that's not applied to living tissue, but is applied to inanimate objects. But in both cases, they're meant to kill or inhibit microorganisms. So hopefully they'll be very, very toxic to microorganisms, because that's the goal of using such chemicals. Antiseptics include soap and water, ethanol, isopropyl, and we'll be having an upcoming webinar later on in the spring regarding some of these hand sanitizers, which use some of those exact chemicals. Disinfectants include sodium hypochlorite or bleach, quaternary ammonium compounds, hydrogen peroxide, formaldehyde, and phenol. And the first three we'll be discussing in some detail today. Next slide. Again, I'd like to thank the PACU program for their generous support and advocacy for this series. It's very important to understand the use and the role of disinfectants, and to make the case for their safe use. So that's critically important, because as we combat the COVID pandemic, there's an increased awareness that there may be a role for some of these chemicals to keep us safe. On the same hand, we have to use these chemicals, these disinfectants, safely. So the PACU has developed a number of resources that are on their website, and a lot of great information about how to safely use these disinfectants. And also, as we'll describe over the next few slides, what are some of the disinfectants that are actually safer to use than some of the other older traditional disinfectants. Next slide. One of the PACU units, the one in Region 9 out in California, is really taking a lead in developing a whole array of wonderful resources. And this is their website, and a lot of great information for use of disinfectants in early child care and other educational environments. And again, I would really encourage folks to visit this website. Next page. Okay, so this is actually an infographic that the PACU has developed along with the Region 9 PACU, and it mentions some really key points. So even before you even think about using a disinfectant, you have to clean the surface. You have to clean it of all the dirt. If you don't clean the surface, the disinfectant's not going to use. So critically important, clean all surfaces. That's rule number one. And we want to disinfect high touch surfaces. And that's really the purpose of the disinfectant is to disinfect the high touch surfaces. And the dwell time for the disinfectant is also critically important, because otherwise, it's going to be less efficacious. Next slide. So not all disinfectants are the same, and there's a wide variety of chemicals that have the categorization of disinfectants, and we're going to go through some of these chemicals in detail this afternoon. Now there are some chemicals that have actually some of these disinfectants have been designated as part of the EPA Design for Environment, or the DFE antimicrobial program. And these are disinfectants that have undergone rigorous review and are deemed to be safer for human health and the environment than other disinfectants. And we'll talk about some of these disinfectants over the next few slides, but one should understand that this has been rigorously reviewed, and the EPA has come up with such a designation. So some of these less toxic disinfectants include citric acid, hydrogen peroxide, lactic acid, and ethanol. And I should mention that it's the concentration or the dose that's critically important, and we'll be going into those issues with some of the subsequent slides, because at a very high concentration, some of these may be toxic, but at a lower concentration, they can be very effective disinfectants with much less toxicity. Now, some of the more toxic disinfectants that have been used historically include chlorine, bleach, and the quaternary ammonium compounds, and we're going to be discussing those as well, just because of the fact that they're so omnipresent. Next slide. So when you go onto the EPA website, there's this page that specifically highlights these much safer disinfectants. And as you can see in the bottom of the slide, approximately 30 products have this designation of being safer disinfectants. Now, on this webpage, there's actually a box. If you go to the next slide. Next slide, please. A box which you can check off to see which of these disinfectants can be used against the coronavirus, SARS-CoV-2. That's important because not every of these previous 30 disinfectants have been deemed to be effective against the coronavirus. And so when you check off the box, next slide, there are 11 products that the EPA has certified as DFE certified for use against SARS-CoV-2. And some of these include some of the hydrogen peroxide disinfectants and citric acid and ethanol. But there's only a total of 11 products. If you can go to the next slide. And when you go to this website that EPA has put out, which is a tool to access all the COVID-19 disinfectants, there's 531 products that have been touted as being effective against the coronavirus. And only 11 of them have that safe designation. So that's really important to keep in mind. And that's why healthcare providers should understand the full spectrum of these disinfectants, with the desire of trying to advocate to use the safer disinfectants, but realizing that many of these disinfectants do not have the safe labeling. Next slide. So this is a list of some of these disinfectants that are effective against SARS-CoV-2 virus. And as described, we're going to highlight a few of them today: the quaternary ammonium compounds, sodium hypochlorite, and hydrogen peroxide. Next slide. Now, if you use this website, you can drill down, and it provides more information about each one of these various disinfectants, including the active ingredients, the contact time that's recommended, 10 minutes in these two cases, the formulation type, and also the use site. And as you can see under the use site, some of them are recommended for institutions, and others are recommended for not only institutions, but also the healthcare environment and residential environment. So one needs to specifically look at where these various disinfectants have been approved for use. Next slide. Now, each disinfectant, each chemical disinfectant has a safety data sheet associated with it. And this is essentially the kind of like the product label. It provides you with lots of information about exactly what's in the disinfectant, what are the ingredients. So, and it comes, there's a variety of different sections to a typical safety data sheet. And this is just an example of a safety data sheet for a quaternary ammonium compound. As you can see in section 2, it provides you with the list of chemicals. Next slide. And section 8 provides information regarding exposure controls and personal protection. And this includes engineering controls such as adequate local exhaust ventilation, which is really, really important. And then also there's guidance regarding personal protective equipment. And so anytime you use a disinfectant, you would be wise to review the safety data sheet because of these recommendations. And they vary from one disinfectant to another. They're not all the same. And so please pay attention to the advice on these safety data sheets in order to use these disinfectants in the safest way possible. Next slide. So if the purpose of a substance is to destroy organisms, can it be harmless? And you have to, again, come back to the point that we use disinfectants to kill microorganisms. We'd like them to only kill microorganisms and not to harm anything else. But we have to look at a variety of different factors here. There's the host, and not all hosts are the same. Some hosts are much more vulnerable to various chemicals than others. And so host factors are very important. The environment where the chemical is used is also very important. Is it a small enclosed space? Is it outside? A variety of factors. And then, of course, the toxicant itself. And so it's the combination of host factors, environment, and the toxicant, which ultimately results in the health outcome. And an understanding of this interdependent relationship is critically important. Next slide. Okay, so at this point, I've finished our first part of this webinar today, and I'd like to hand it over to my colleague, Dr. Ashley Haynes, who's going to go into more detail on the quaternary ammonium compounds.
All right, thank you. We can go to the next slide. So quaternary ammonium compounds, oh, we lost a picture. These are sometimes abbreviated quats or quox. So I will probably say quats a few times when I'm talking about this group. They all share a similar structure, and that's how they get lumped together with a nitrogen with 4 side chains. And that's the picture that used to be there and seems to be missing right now, and a positive charge. These comprise about half of all of the disinfectants you're going to find. It's over about 210 of what was listed on that N list. And it is a large group that are all based on structure lumped together. Historically, benzalkonium chloride was the most commonly used, and for disinfecting purposes has been replaced with a lot of newer compounds. And this is important because in production, the production of these in May of last year was equivalent to all of 2019. So we're seeing more and more of these and more used. Next slide. How do these act? Oh, lost a picture again. Okay, they interact with cell membranes of the bacteria or the lipid membranes of the virus. So they do have that positive charge. Remember, those outer cell walls or lipid walls have a hydrophobic and hydrophilic portions where there are charged portions. So it will initially adhere because of those charges, and then that will further disrupt the organization of that outer membrane and allow stuff to start leaking out through. This is effective against fungi, bacteria, and the lipophilic enveloped viruses, which include SARS-CoV-2. Not effective against spores, mycobacteria, or the non-enveloped viruses. Next slide. So a number of common products, including, as we mentioned, benzalkonium chloride being the most common. So this we see often put into other products as well as a bacteriostatic. So this is sometimes used in like albuterol solutions, eye drops, and nasal sprays to sort of halt any bacterial growth, not necessarily as a disinfectant, but it is present in a number of other products than just disinfectants. The ones that are used most commonly as disinfectants include didecyl dimethyl ammonium chloride, or DDAC. And these two, benzalkonium chloride and DDAC, are probably the two most commonly studied. But these kind of middle range alkyl dimethyl benzyl ammonium chlorides also occur quite frequently. Most of your wipes are going to include these. The picture that seems to have gotten lost again included shampoos and lotions. These contain polyquaternary or polymeric quaternary ammonium compounds, which are long chains of these compounds together. And so what this can do is sometimes cause a change in the charges to allow kind of smoothing properties, or to have them adhere to surfaces for longer periods of time. So when you're talking about a lotion, if it's, kind of helping stay on the surface of the skin and maybe have some smoothing properties, or with shampoos, helps disrupt the electrostatic charges that cause static in your hair. Oh, that looks better. I think, there you go. Cause the static in your hair so your hair is not sticking up all the time. I do want to point out a couple things. Obviously, we're not kind of using product names. We're trying to be sensitive to that. However, there are certain products that have been around long enough that many people associate them with one type of chemical or brand. I'm going to give an example that is not an endorsement, but just often people hear the word Clorox and they think that that means bleach. But that's not always the case. So Clorox makes a number of products that are not bleach, including quaternary ammonium compounds. And that's true of a number of different brands. So you need to be careful and pay attention to what is actually in that product, because it may not be exactly what you commonly associate with that brand. Okay, moving on. Next slide, please. So for appropriate use, these are to be applied directly to pre-cleaned surfaces. You want to remove dirt and grime that may interfere with the ability of the quat to contact the surface. It has to make contact or it can't disinfect it. Dwell times will vary by product and by concentration. Almost all of them need at least a minute. It can be up to 10 minutes. This means time where it is actively wet. If it dries before the end of that time period, then a reapplication is okay. It just needs to be wet that long. After that time period, if it's still wet, then you can wipe it and remove it. But if you wipe it immediately before it's had that long of time, it may not have had adequate time to disinfect. Some products are concentrated and do need to be diluted, and that will be per the manufacturer's guidelines. All the products are kind of a little bit different. Most of the home care products don't require dilution, but some can. Many that are used in industrial settings will often require dilution. Cotton or gauze pads should be avoided because these will absorb and stick on there. So then it's all stuck to your cleaning pad and it doesn't actually contact the surface or stick on the surface to leave that dwell time. It's important to try to avoid direct contact with the products and use gloves. If you're aerosolizing or mixing these where they're going to be kicked up into the air during the process, you do want to be in a well-ventilated space. They don't vaporize off, they will dry on the surface. So afterwards, it's not like the vapors are going to come off because they don't make vapors, but you do want to remove residues because it can leave a residue behind. And those residues are not food safe, so you don't want to use them on food preparation sites. Next slide, please. With acute toxicity, there's kind of two major areas we think about. Dermal. At high concentrations, there can be corrosive effects. So we think of about greater than 7.5% for benzalkonium chloride. The other various quaternary ammonium compounds may have different concentrations, but high concentration ones may cause burns. Lower concentrations, you may have some irritant effects, irritation, tingling. With ingestion, you can have burns to the mouth or esophagus, obviously more common in a more concentrated product. If enough's ingested, there can be sinus depression, hypotension, there's a risk for aspiration. These are less common, but this is going to be with like an intentional ingestion. Moving on to the next slide. If you look in textbooks or you do a Google search, you may see scary sounding things that are side effects, including methemoglobinemia and hemolysis. These are usually in the setting of really unusual exposures. So there's been some cases where people did some peritoneal irrigation and developed methemoglobinemia. We don't do that routinely. That's not something that would ever be recommended for its use. There have been people who have used this parenterally, sometimes that's in the setting of a suicidal gesture, that have developed hemolysis and cardiac arrest and muscle paralysis. Injection has also been associated with paralysis in animal studies as well, when they were just examining toxicity of these agents. And they think that this is probably due to similarity in structure to the cholinesterase inhibitors. So when you think about like the organophosphates type agents. Next slide, please. Management, generally, it's going to be similar to other caustics. So removing it from the skin, cleansing from contact. If there's a more than a taste of a high concentration, or if they have symptoms, they should be seen in the emergency department. If there are symptoms like drooling, chest pain, oral lesions, that may indicate need for endoscopy to evaluate the esophagus. Otherwise, most care is going to be supportive. Next slide, please. So there are some chronic issues that occur with re-exposures. So sensitization is one of the major ones we think of associated with quaternary ammonium compounds. OSHA defines this as basically when you have re-exposure to people or animals to a compound that causes a development of an allergic reaction in normal tissue on re-exposure. Typically what we think happens is that a previous exposure leads to the formation of IgE, and then when you're re-exposed, you cross-link that IgE and activate inflammatory pathways, which includes activation of lymphocytes, eosinophils, release of cytokines, chemokines, histamine, and so forth. And these can lead to further reactions. So next slide. Next slide, please. The first kind of group of reactions are going to be dermal effects. So in the skin, these penetrate, they're kind of like a half antigen. They start to get attached to carriers in the deeper tissues and then form a full antigen, which is capable of activating an immune response. So on re-exposure, you can develop contact dermatitis. They can also just cause irritant effects as well. And with really chronic exposures, you can get this granular parakeratosis, which is kind of chronic reddening of the keratin structures in the skin. In one study, up to 4.5% of patients who had previous contact dermatitis were actually positive on patch testing to benzalkonium chloride. Next slide. And then the other concern with sensitizers is occupational asthma. So to break this down, there are kind of two types of occupational asthma: sensitizer induced, which is what we consider from the quaternary ammonium compounds, and then irritant induced. There are a couple of differences. So with sensitizer induced, this is an immunologic phenomenon where after exposure, as mentioned, IgE is produced. They may not be symptomatic that first time, and then re-exposure leads to that inflammation and obstruction that's consistent with asthmatic symptoms. There can be specific inhalational tests that reproduce these symptoms, so you have them, be exposed and then check PFTs. With irritant-induced asthma, this is not allergic. They're typically symptomatic on the first exposure with little delay, and the diagnosis is largely based on history. For the most part, evidence suggests that quaternary ammonium compounds can contribute to a sensitizer-induced picture of occupational asthma. Next slide, please. There have been a couple of case series that did look at these, where they did specific inhalational tests. So they'll have a number of people that were all exposed. They had history of occupational asthma, and then 10 were positive for when they were given the quat test, and their PFTs were consistent with sensitizer. Another case series of 16 patients that were exposed to 28 minutes of their lowest concentration of a common workplace exposure of DDAC, and 20% of them dropped they had a 20% drop in FEV1 that was considered a positive test. There has been a recent review that looked at the prior literature and the strength of evidence that questioned whether these were truly originated from the quats. There's certainly enough evidence to say that it exacerbates asthma in those with underlying asthma. So it's partially because there's just so few studies, and the studies are very small, or they're individual case reports rather than large exposure, large trials. Next slide. So if occupational asthma occurs, acutely, you're going to treat fairly similar to other asthma. You're going to use bronchodilators, steroids if it's, severe enough wheezing. Long-term avoidance is really the key. So maybe that means your workplace changes agents and you don't use that anymore. If you're spraying it, trying to avoid contact with your eyes and your face, wearing a mask or eye protection, and then making sure that, residues are removed. Okay, next slide, please. A couple of other concerns that have been raised have been some reproductive concerns. There are a couple of mice studies that showed longer times to litters, smaller litters, and decreased fertility. There are a couple of criticisms with these because these are very high exposures, 50 milligrams per kilogram per day by gavage, some of them with intraperitoneal installation. And to compare, I looked at one of my common products in my home, and it would be like me drinking 3 to 4 ounces of that every day for 8 weeks. So it's kind of not realistic to the exposures we typically would think of as a chronic exposure. There was one observational study of rats that moved labs, and in the new lab, there were quats being used to clean things that they did not believe were being used in the prior lab. It's unclear how those were used or how they were affected, whether it was being cleaned on the cages, whether it was on their packing in their cages, or whether it could have contaminated their food. Remember, this does leave residues. So if residues aren't removed, rats do some things that most adult people, at least, or bigger children people, don't do, including like licking the sides of the walls, chewing on packing and flooring. Next slide, please. And then there are some concerns about the environmental fate of these. So they're stable, which we usually think of as a good thing, but in this setting, this means they're very slow to degrade. So they persist somewhat for 7 to 10 days in the environment. And some marine bacteria can degrade them, but not all. The frequent endpoint of these is wastewater. They get washed down drains or washed off if you're washing something outside with them, and they end up in wastewater. So they can stick to sludge and inhibit those microbes, the kind of good bacteria in the sludge that are breaking down other stuff. So it can disrupt wastewater processes. Additionally, you may need longer times or higher concentration of microbes to break these down. And there have been reports from wastewater plants that they've already had to change their processes a couple of times over the last year due to increased quats in wastewater. And if they're not removed and they go into the effluent from the plants and through the treated water, there can be genotoxicity to crustaceans. They can be algae static that can affect the amount of oxygen in the water to that area and have downstream aquatic effects. Next slide, please. And then there are some indoor air quality concerns. So as I mentioned, pre-cleaning is important. If you just spray this on a dust and then you get this stuck to the dust and the dust goes up into the air, that's a route where you could potentially become exposed. And then it leaves a residue. So there's a potential that the residue could flake. In 2007, there was an indoor air quality study of hospitals that really showed that there was not any measurable quats in the air there. However, in 2008, we started to look at what's actually in house dust. And I think you can imagine that the amount of dust in your house may not be the same as in a hospital. Pre-cleaning and post-cleaning is definitely different in those two settings, and ventilation and airflow also, as well as filters. And then over this last year, there have been some studies that looked at the amount of quats in residential dust, and we saw almost a doubling was noted in the first half of this kind of pandemic due to increased quats in residencies. Now, unfortunately, we don't have like a, hey, if you breathe in this concentration on your dust, that's going to be a problem. So we don't really know what number is important. We just know that it's there. And we also don't know if there's a difference between the individual quats. Is one more sensitizing than another? If you have a problem to one, will you have a problem to another? Those are things that just we don't have enough data to say for sure at this point. And I think at this point we can go to the next slide, and we'll be moving on to Dr. Kazzi and bleach, or sodium hypochlorite.
Thank you, Ashley. Hello, everyone. I'm going to cover bleach, sodium hypochlorite. So basically, chlorinated bleach. This is actually an interesting follow-up after Ashley's presentation, because we do share some of the same issues and are different in some ways as well. Now, of course, chlorine bleach is very commonly used, probably one of the most commonly used disinfectant, and it's been around for many, many years. Used in disinfectant purposes, as well as some other bleaching purposes, industrial setting, residential setting, childcare, healthcare. So certainly a major stakeholder here. And of course, it varies in its concentrations as well. Of course, the industrial concentration is what we're not going to talk about today, is greater than 10%. What we are going to focus on is more of the residential healthcare setting of 5% to 8% concentration that is diluted, usually depending on what you're trying to do with it, specifically where you're applying it and for what reason. The other confounding issue with sodium hypochlorite, which is the chlorinated bleach, is that it is often mixed with additional chemicals like surfactants, fragrances, sodium chloride, sodium silicate, sodium hydroxide, antioxidants, and anti-foaming agents. And if you can go to a supermarket or a store, you will find there are numerous different products that are based on sodium hypochlorite bleach, but have a variety of other ingredients in them. Next. But essentially, the disinfectant product is the actual sodium hypochlorite that is converted to hypochlorous acid. This hypochlorous acid is going to react with amino acids, leading to bacterial protein damage, for example, when you're using it against a bacteria. It's also been shown in some recent research that actually affects the unfolding of proteins. And these proteins, when they unfold, they cause this oxidative stress on the microorganism and its death. Next. As Dr. Wax has emphasized, as well as Dr. Haynes have emphasized, it's very important to follow the directions on the label. It's very important to consider the dwell time, which varies depending on the concentration of the product you're using and the indication. But you can see products at least 1 minute, 4 minutes, up to 10 minutes after you clean the surface again. And it's particularly important with bleach to clean well, because any organic material that is on the surface can react with this highly reactive compound, and that can release additional volatile organic compounds that have a different set of problems than the sodium hypochlorite as well. And that's probably one of the most important lessons in my part of the presentation. You have to follow the instructions because there are dilution steps that you have to take. For example, if you are to use a 5% product to reach a 0.5% concentration, then you have to dilute it appropriately to do that. And if you don't follow these instructions, you probably get the wrong dilution. And also the process of diluting it and mixing it in your workplace or your home, that potentially can also expose you to spills or additional exposures that are otherwise, unrecognized. Next. Again, the most important thing I want to relate to you is this reaction between bleach and organic matter on the cleaning surfaces, because these volatile organic compounds can be more toxic and have additional health consequences than the parent compound, which is sodium hypochlorite, such as chloroform, carbon tetrachloride, formaldehyde. And these can be actually released even more when you are heating the bleach in a laundry machine, for example. So that's why it's important to ventilate properly when you use it and keep these byproducts in mind and try to decrease their production by certainly using this on a clean surface if you can. Next. Now, every toxicologist would love to discuss the acute toxicity as well in any presentation. And of course, bleach is commonly seen in acute toxicity because it's laying around commonly in the house, often improperly stored, and definitely proper storage of these chemicals at home is essential. And unfortunately, children or even adults accidentally ingest bleach relatively commonly. And we hear about these cases in the hospital as well as in the poison center. Now, luckily for us, most of these dilute products, household products, will not cause any major issues. Actually, if they're asymptomatic, we don't even ask them to go to the hospital if they call the poison center, because most of these symptoms are irritant in nature and minor and inconsequential. However, if you have a suicidal patient, drinks a lot of bleach, or if you're drinking concentrated bleach or industrial bleach, then you need to go into the hospital. And you see here one of my patients in Birmingham, Alabama, that had developed some superficial gastric ulcers or erosions after ingesting household bleach, a large amount for suicidal intent. Next. Also, occasionally, I see patients that have bleach splashing in their eyes accidentally, or sometimes, intentionally. Somebody, throws bleach at them, and that can cause some chemical conjunctivitis that needs irrigation. Of course, an eye exam with fluorescein staining, and then irrigation with saline using a Morgan's lens if you have one, and then reassessment of the eye. And sometimes, if it's severe enough, you may need to consult an ophthalmologist, depending again on the concentration of the product that was involved in this case. Next. The third important topic with bleach acute toxicity, apart from the ingestion and the ocular exposure, is mixing these chemicals. Unfortunately, some people believe that mixing two chemicals is better than just one or two separately. So the mixing them up, they think that this is going to be even more powerful disinfectant. And sodium hypochlorite in particular, when you mix it with ammonia, you can generate a very toxic irritant gas called chloramine. And if you mix it with acid, you can generate chlorine gas. And of course, we've all heard of chlorine gas in chemical warfare, and it can cause severe toxicity to the airway, upper airway, lower airways, depending on the concentration. It can be fatal at times. Next. And here's an example, actually, of somebody who's was inhaled a large amount of chlorine gas and developed this chemical pneumonitis. Now, luckily for us, we don't see these very often. Most people, are going to be concerned about low-level exposures. to these chlorine or chloramine gases that can be produced when you're using bleach, even on organic material on the surfaces. And low-level exposure can be detected by some people when they feel some burning in their throat or lungs, and nose irritation, chest tightness, coughing, and sore throat. And these are pretty minor. However, when these concentrations are higher, they can be consequential. We've seen people in our clinic that come to us with a irritant-induced asthma, such as reactive airway dysfunction syndrome, which is following an exposure to high concentration of irritant gas, such as chloramine or chlorine. And certainly bleach can be involved in these scenarios, and would be a problem that you would see in your clinic and can be affecting the patient for several months, several weeks, and several months, and even a year or two after the exposure. Next. But when we move away from these high dose exposures, we still have a concern to address today together, which is the low level repeated exposure to sodium hypochlorite. And I want to discuss dermal, respiratory, and cancer. Next. The first one is easy. It's a dermal effect. I say that it's easy because if you look at sodium hypochlorite and dermal effects in terms of sensitization, there are very few case reports out there. The problem is that people are exposed to sodium hypochlorite, soap, hand sanitizer, water, and when they come to you in clinic, it's usually a mixed picture. And unfortunately, it becomes difficult to try to differentiate what's going on here. But you want to think of atopic dermatitis, irritant contact dermatitis, allergic contact dermatitis, and non-allergic contact dermatitis, which is the irritant one. And this happens because people really remove the protective layers of the skin, whether it's fat or the upper layers of the stratus corneum, and that makes the skin much more vulnerable to potential irritants or chemicals added to a variety of products that you use every day. Next. And I just want to show you some pictures here. And you don't even have to look at these pictures. Nowadays, during this pandemic, you can look at your own hand and you can recognize that you have some dryness, which is one of the first things that happens. This dryness can eventually become thickened and becomes really kind of sclerotic. Next slide. And even darker. You can see here some acanthosis from the repeated use of these products. Not necessarily just sodium hypochlorite per se, but the mixture of all of what we're doing to keep our hands clean. Next slide. Rarely you could see a chemical specific allergic reaction. As you see here, some erythema with some vesicles. These are occasionally happening in people that are reacting to a specific chemical. Now, these are the type of case reports that are not very common with sodium hypochlorite. If you look at the literature, you only can find less than a handful of these reports. Next, please. The other important topic is respiratory effects, and one of them is asthma. Big question, if I'm using sodium hypochlorite, am I going to develop asthma? And what if I have asthma? Is my asthma going to be exacerbated? And I saw a patient recently that had exactly the same scenario. She was asthmatic. I treated her. And then I asked her, I said, how's your asthma usually? She said, well, I haven't had any attack for 10 years. And I said, well, what happened? And she said, well, I started cleaning at a mall recently. So just begs the question of asthma being exacerbated by bleach. And I think the answer is yes. We have, the sodium hypochlorite itself. We have the volatile organic compounds that are released, like I said earlier, like chlorine or chloramine. And these can exacerbate your asthma. And I think people that have been doing work with these products complain of more cough, wheezing, and those who are asthmatic complain of more frequent asthma exacerbations when they're working with these. The $1 million question is, does sodium hypochlorite induce asthma in someone who otherwise does not have it? And I think here we have some evidence that sodium hypochlorite is a sensitizer and can induce asthma. For example, the Association of Occupational and Environmental Clinics database lists sodium hypochlorite as an asthmagen. This is the term, asthmagen, or induces asthma. And there are some studies in workers that use sodium hypochlorite frequently that have a higher risk of asthma. And also there's some dose dependence. And if you look at animal studies or even patch testing, you do find some evidence for sensitization. Now, unfortunately, these associations, need more research, like any of our scientific associations that we recognize in our research, because association needs to be removed to causation, and that requires really a lot of research and effort. So it's important to keep in mind that yes, there is evidence that sodium hypochlorite is an asthmagen and can sensitize you to develop asthma. based on the studies that we have so far. Unfortunately, there's also counterscience that says that bleach helps you, reduce indoor allergens like mold and dust mites, and those are known as well to be asthmagens. So again, this is the pro and con assessment, or the risk-benefit assessment that you need to consider if you have to use sodium hypochlorite as opposed to the safer disinfectants that are currently available in our everyday life. Next. Finally, cancer. There's a good news and bad news. The good news is that as of now, when you look at the International Agency for Research on Cancer, IARC, sodium hypochlorite is not classifiable as to its carcinogenicity in humans. So there aren't enough studies in animals or humans to analyze or assess properly the risk of cancer from sodium hypochlorite. But remember, I told you there are some byproducts that can be released when you use sodium hypochlorite. And those byproducts, such as carbon tetrachloride, chloride, or chloroform, are more concerning from their carcinogenic potential and are classified by IARC as group 2B as possible carcinogenic in humans. And thank you.
Okay. Well, why don't we move on now to the hydrogen peroxide considerations. And hydrogen peroxide certainly is something I think everybody is familiar with from the brown bottle usage, in the home for a number of different indications. And unlike some of the products that have just been described, it does have a side benefit that because of that bubbling action, which is actually that energetic release of oxygen, you can get some cleaning from the application of the agent itself. And as Dr. Wax had mentioned, cleaning is of utmost importance, at the beginning of the process, because you can't disinfect a dirty surface because of just biofilms and just too much lack of contact between the organisms and the disinfecting agent. The disinfection part of hydrogen peroxide use is through its generation of hydroxyl radicals and acting as an oxidizing agent within the cell itself or with at the lipid membrane or wall to disrupt those components of the cellular function. If you think about how we typically use hydrogen peroxide, that is the metal interaction. The interaction with metals is what we base a lot of our indications on for household use, cleaning blood stains, for example. That bubbling action on blood is actually a catalyzed reaction because of the presence of iron. And so iron itself can become both a accelerant and other metals as well to the activity of hydrogen peroxide, or potentially degrade its use if it's stored in improperly. Some organic compounds can also both inhibit and or accelerate the activity of the hydrogen peroxide, the agent. If you think about this, hydrogen peroxide and formation of hydroxyl radicals is something that our cells use all the time to kill other organisms in the area. And we even have defense systems designed to break down the hydrogen peroxide, and predominant among those is a catalase. So in a sense, you'd say, well, hydrogen peroxide is natural and it's a component of our own body's reactions, responses. It's maybe the preferred agent. And that reasonable stance to take, although you do need to recall that concentration and therefore dose is still the critical issue to consider. So as Dr. Haynes mentioned, when you are applying these substances as disinfectants, you need to make sure that they have an adequate contact or dwell time in order to do their job. And that job depends on what it is you're trying to kill. Now, right now, this webinar, and of course, all our attention, it tends to be focused on the issue of killing the SARS-CoV-2 and preventing COVID-19. But in the setting of a daycare or a school or an office building, you have other issues. Influenza virus is not really a problem this season, but other adenovirus and other cold viruses that you will need to also want to diminish the presence of, and those may require a longer contact time than the contact time for SARS-CoV-2. It's always important, as has already been mentioned, to follow the labels that are on these disinfectants, because all EPA approved disinfectants have labeling requirements that are put in place by federal regulation. And therefore, you should not try to contravene that in terms of the indication that you're using it for. It makes no sense at all to apply by wipe or spray disinfectant that has a dwell time of 1, 3, 5, or 10 minutes for whatever the intended purpose is, and then wipe it off after just a few seconds. That does nothing other than possibly clean the surface some, but that doesn't lead to a sufficient drop in terms of the log kill or log decrease in organisms on a surface for a highly contaminated surface. And those become big issues in terms of trying to apply these principles and products in general. Acute toxicity is dependent on concentration, and generally we think of hydrogen peroxide as having very, very little toxicity, but it is a corrosive, an oxidizing agent at high concentrations. And there are some particular problems that come if people are using concentrated products directly or fail to dilute them appropriately. And we'll get into that on the next slide. Chronic toxicity from acute exposure is not really expected unless it were directly from say, an eye injury. Next slide. So what does that mean in terms of the range of toxicity we're talking about? So a lot of the especially some of the newer ones coming out with either transition metal or sometimes some organic compounds, particularly acetic or peroxyacetic acid, are often present in low concentrations, 1/2 of 1% or 1%, 1.4%, that kind of range, and dwell times or contact times in a minute to 3-minute range for viruses either like SARS-CoV-2 or for SARS-CoV-2 itself in terms of the demonstration of effectiveness. So those are very useful, very safe, and the preferred products, as opposed to things you might think about say diluting your own or making your own disinfectant. So common household commercial hydrogen peroxide is 3%. It's fine for cleaning stains and fabrics and even for cleaning dirt out of a wound, that kind of thing, a surface wound. But think about that. That's the same concentration as what is in the disinfecting bottles for your contact lenses to remove proteinaceous debris and disinfect the lens. And those are highlighted warnings that you do not put that directly into your eye, because it will lead to a corrosive injury to the eye, particularly with prolonged contact under a contact lens. That degree of toxicity kind of pales in comparison to the so-called food grade hydrogen peroxide that is also available. It can be purchased over the internet or in supply houses. And it's very confusing because it's listed as food grade, but that has nothing to do with you taking that in as food or even on your food. We'll go to the next slide. So hydrogen peroxide, in bulk and in high concentrations could be used to dilute and to make your own, disinfectant. But the problem can run into troubles with the accuracy of your dilution. And you are also, as Dr. Kazzi mentioned, with bleach and other mixtures, you can end up with a product that is available and inadvertently expose children and others to, because these are clear, colorless fluids. And if you've put them in containers that are not appropriately labeled or not locked away, people may mistake them for something else. And we have a large experience with people who have taken inappropriately, based often on internet recommendations about the quality treatment for using hydrogen peroxide. And they've taken these full strength and again, food grade means that they've been approved by the FDA to treat food packaging or to bleach food in processing. And it's okay if there's some residual of that left as it goes through the food processing chain. It's not, it doesn't mean it's to be used as food, and it should never be taken internally or injected by any means. But people have swallowed these, and they end up with a significant injury. And I'll show you in a moment what can happen from that because of the rapid elaboration of a very, very large volume of oxygen gas. And sometimes there's just confusing recommendations. There's one product out there that says that 11 drops of our 3% product is equal to 1 drop of 35%. Well, the transitive property of mathematics means that's about right if you are multiplying together, but it has nothing to do with what's happening if you actually put that into, say a container of water or something like that. So it's just not an appropriate use of these higher concentration products. Next slide. So this is what can happen when you ingest even a small amount of these high concentrated hydrogen peroxide products. And 1 milliliter of 3%, this is your household, will elaborate 10 milliliters of oxygen. But that means that 10 milliliters of 30% will elaborate about a liter of oxygen. And a liter of oxygen gas in a small space, such as your stomach, will overcome pressure within that organ and force that oxygen out into the tissues. And then you get air emboli, well, oxygen emboli. And you might think, well, oxygen, isn't that supposed to be in our bloodstream? And yes, but it's supposed to be carried, connected, bound to hemoglobin molecules, not as large bubbles. And you can end up with strokes and other disabilities because of that. And again, that's from inappropriate use of a high concentration product or from lack of dilution or appropriate dilution of a product. Okay, let's go on to the next slide. So Dr. Wax had showed you the DFE program, and for hydrogen peroxide products, at this point, there's only 2 out of those 30 DFE certified disinfectants that are hydrogen peroxide. This list is growing and changing continuously. Even the overall in list is increasing, from the 400s to 500, mid 500 number of compounds. So I would encourage you to go look at that. And if you have a product, start out with the N list, and then go down to this list if you're looking for a safer selection of disinfectant chemicals. Next slide. Chronic exposure, exposure again and again, or on an ongoing basis. This is used as a bleaching product, so it could cause bleaching of skin, but that's generally from soaking in it and not from just using it on a wipe or wiping up a spray after a contact time. So that's not very much of a concern for the dilute, ready to use products that are labeled disinfectants. It can be an irritant to skin mucous membranes, and there are recommendations out on the internet about inhaled treatment to try and prevent COVID-19, inhaling hydrogen peroxide. That should not be done. That's an easy way to exceed even the occupational threshold of exposure and lead to irritant, cough, and if you have an asthmatic tendency, potential of asthma exacerbations. Particularly, that'd be more of a problem even with children because of their smaller airway size. As with the sodium hypochlorite, this is IARC group 3, so it's not classifiable. There are very few animal studies that with concentrated or with oral administration that suggest some potential for a small bowel tumor development. But again, that's not the way you would use it, and certainly not the way you'd use it as a disinfectant. Because of the move to try and make this more useful and having less contact time required, at least for some organisms, a number of different compounds are out there called accelerated or modified or stabilized hydrogen peroxide solutions. And those are usually pH adjustments and or incorporation of some organic acids or transition metals. So when you see an inert or other ingredients making up 98, 99% of a product, that doesn't mean that there's not something there. It just means that they are not necessarily used for the purpose of the product, in other words, as a disinfectant, but in some way to improve the stability or utility of the product. And so you want to look at those inert ingredients. EPA maintains a list of inert ingredients that are approved. Sometimes the companies don't provide those on their label because they're considered proprietary information. Next slide. So in summary, for the three types of compounds that we've talked about, if you look down this list, you can see the concerns regarding potential for acute exposure, chronic repetitive exposure, either because of potential, again, mostly theoretical, but potential for long-term effects, and then the association with asthma and sensitization, either by irritant effects like RADS from chlorine that Dr. Kazzi had talked about, or the potential, for actual allergen sensitization that was described for both of those products. And from looking at this list, you might think that, certainly across that spectrum, hydrogen peroxide products would have the, win the battle, as it were. And the concern would just be, again, if you have concentrated product, or if you are in an area where children or others who are not responsible for the cleaning are going to be, you have to make sure that those products are well labeled and kept locked up and away. Next slide. So you may ask, and I see that we have a number of questions, some of which have asked this, so what should you use? And we're joined now by Dr. Timur Durrani, who was one of the authors on this paper that came out just, now 2 years ago, I guess, but asking that real, kind of bottom line question is, what should we use in a given setting? And we've run right up against the hour now. If people are willing to hang on there and bear with us, I'd like to take just about 5 minutes or so and run through just a couple of scenarios that I hope will address some questions you may have, and then turn to some of the questions that the other presenters have been kind of looking through as well. So why don't we go to the next slide, Timur? With this paper that you guys put out, there was a real effort, I think, to come to that combined point of what products are being used, but also what process is being used and what is the setting that it's being used in. So, we've set out these three potential, typical settings for use of disinfectants. You want to just go over some, kind of highlight some points. We'll start off with the offices, or even a medical office, but office or a business setting. What are the features there that become important in terms of applying a disinfecting process?
Yeah, thanks. So the study that we and my colleagues from the Western States PACEP at University of California, San Francisco, set out to look at in 2018 was we looked at the EPA database of hospital grade disinfectants and found the three big chemicals being used that have been reviewed here. So bleach, quaternary ammonium compounds, and hydrogen peroxide. And then we reviewed the toxicities as we've seen by our three previous presenters. And what we came to find was that with all things being equal, from the chemical that would be cause the least amount, at least from a pulmonary standpoint, issue where we have people working and breathing and cleaning in the same, or disinfecting in the same space, was a hydrogen peroxide. And we go into some of the details with regards to particularly in child care settings, but I think some of this can be extrapolated to other scenarios. So for example, in the business office and business setting, I think the first point to make is that all of these chemicals need to be used in the appropriate manner. We're currently in the COVID pandemic, but a lot of us remember when we were in dealing with Ebola just a few years ago. And there are a lot of concerns, particularly in the toxicology realm, of people trying to mix chemicals, thinking that it would be a really good way to kill something like Ebola. What we found was that we had side effects more from the chemicals than we had actual exposures. And so what we find in the office business setting then is ensuring whatever chemical is going to be used is used according to how generally how the manufacturer has described it. We found that hydrogen peroxide can work in all three settings, as well as the other products. We find that with hydrogen peroxide, it has less of the pulmonary concerns. There are other things to take into account, as you've seen, but that's what we find in these high touch surface areas in the home, in the office and business setting. With regards to the home, what we've gone over here, really, again, I think hydrogen peroxide is sufficient. I noticed there's some questions in the chat, which we didn't go over with regards to vinegar, but vinegar is another one that we've recommended in the home care settings. I think it's important to sort of point out, as we have on the slide there, that animate objects, things like mail and groceries and things like that, we generally don't recommend any cleaning, disinfecting, or at least disinfection with, mostly because the evidence has shown that we just don't see much transmission, and I'm not aware of any paper that shows transmission from these objects.
You've even seen a little bit, coming out now about the, the fomite transmission itself for SARS. COVID-2 is fairly low and very much dependent on things that maybe are not much of an issue at most homes, unless you happen to have somebody who has COVID-19. So a lot of the data that's out there it really has to be interpreted in this setting, right? So general community transmission by surfaces is pretty low. That's not the same as, because that's, because at any given point in this last year, you may be dealing with a 0.1 to a 5 maybe percent prevalence in your community. But if your community happens to be your home with 1, 2, or 3 people who actually have COVID-19, well, that's, that's no longer that setting. And so some of the questions people were asking is, if I clean these high touch surfaces, what are they in the first place? And how often do I have to clean them? Well, if in a home, you can clean things when they become dirty, as you would usually do, but disinfecting becomes more an issue of what has happened that would make you think that. So if you've had visitors in your home, and everybody is healthy, but you don't know if somebody may be asymptomatically infected, then it may make sense to disinfect after they leave or before they come to help them out. But it doesn't mean that just every time somebody goes in and out of a room, you need to disinfect that surface. An office setting, that may not be the same rule, because now you have all kinds of people coming in and out potentially. So, and particular regards to the childcare issue, I know you guys looked at this some, and certainly the PACEP information and training that's being provided really does focus on, while we may come up with a number of different compounds, when you are in a setting, even an office, because you have employees and therefore an OSHA regulation regarding your duty to care for the employees. But in a childcare setting, you have a number of different entities that are providing your certification or your licensing or whatever else, and you need to follow the regulations that are in place. So there are defined regulations for how often to clean in childcare settings, whereas at home you may not, disinfect a changing table every time you use it, but you would want to clean the pad that was being used. In a childcare setting, that's a requirement. So the issues then become, what disinfectant do you choose? Well, you have to, in those settings, use an EPA approved disinfectant. You can't just making up, your own. And you also have to use it, therefore, in the way that the label says. That becomes a problem, and I think you guys addressed this in the paper, that if you now are in a childcare setting that happens to have very poor ventilation, and you're doing frequent diaper changes for your, young children that are in your care, then you are going to be, applying disinfectant much more frequently. And in a place that maybe only has, I don't know, 1 or 2 air exchanges every hour or 2 or 3 instead of 2 or 4 or 10 air exchanges an hour like we think of in the healthcare setting, you may not want to use something that is either volatile or that tends to have fumes that will hang around because they won't clear as quickly, and you'll have young children then that'll be exposed to those. So I guess the key is trying to apply all of the available information and substances to the settings that you're actually going to be functioning in. And maybe the importance, is to take away, that you want to make sure you can address some of those other issues, like ventilation, opening windows if the climate will allow for it, the weather will allow for it, installing exhaust fans if you have either the need from your business setting or the wherewithal in terms of finances. I think we should probably get to some of the questions because I know we were holding people over now extra. Anything else you'd want to say about one of the areas here before we go to some of the questions, Tim?
No, I would just, reiterate, as we got into the childcare setting, what we found was that it's a unique environment where we have both, children who are in different stages of development, as well as the caretakers who are working there. And depending on the size of the daycare, oftentimes these are in homes, and a particular portion of the home has been designated as the changing area. But you can imagine there's pretty frequent amount of changing in these environments, and with open areas with stool, feces and so forth. And so, as you mentioned, Chuck, as regulations require, every time a diaper is changed, depending on where you're at in the country, the area needs to be disinfected. So you could have a fair amount of chemical exposure. That was part of the reason where we settled on hydrogen peroxide. And so extrapolating that to the home and the office then, which should have less amount of some of these, let's call them contaminants with regards to things like feces and such, and ideally better ventilation. We're confident in at least our opinion with regards to hydrogen peroxide. That's all I have. Thanks.
And I've seen some people are asking questions like, would prompt cleaning, avoid the need for disinfecting, or isn't cleaning enough, soap and water? Why do we need to go to a sterile environment? And these are different terms that are thrown around. And I'd invite, Paul and Ziad and Ashley to come back on queue and we can go to answer some of these questions. But if just to answer that one in general, certainly soap and water cleaning first is the primary and most important thing. If you are in a setting where it's family members only and that may be all you need to do. Certainly we brought up our children not disinfecting, the changing area or their rooms or anything. But if you're now with multiple children from multiple families, you're not only, of course, now for SARS-CoV-2, but for a number of viruses or bacterial pathogens, there are concerns about the adequacy of just cleaning, because you take something that has saliva on it and you're asking a cleaning agent to remove all of that, and you may get 3 or 4 orders of magnitude decrease, but you may have wanted to get 6 orders of magnitude decrease. And that's where you need to go with an extra step, and that is the disinfectant. So it is a staged process. It's applied then to the particular setting that you're in, and remembering that if you're in a commercial setting or some of these regulated settings, then you have additional requirements. You guys want to queue up some of those questions, other questions?
I'll throw some of them out. I realize it's already almost 15 after the hour. We will be done before the bottom of the hour. So we want to be respectful of everyone's time. I'd like to thank all the presenters for really an excellent presentation on a very interesting and complex topic. So a question that's come up is actually an interesting one about wearing masks and given the potential need for PPE when using disinfectants, do these masks that we now have become accustomed to wearing, do they provide any dual respiratory protection while disinfecting? So would anyone like to take that one on?
Well, I'll just start off. I mean, certainly no mask, no cloth mask or general surgical mask or any other barrier mask is going to stop gases from going through. So if you're concerned about or thinking you might be able to prevent some of the issues from mixing, say, of chlorine, bleach, and ammonia, or chlorine, bleach, and acids, that won't help you there.
But in the setting of quaternary ammonium compounds, where you're thinking more of droplets, if it's the actual product, then the masks should help reduce that, as well as some, dust particles as well. Though I don't know if everybody wants to wear a mask instead of dusting their house.
Okay, great, thank you. So we talked a lot about the importance of cleaning a surface prior to the disinfectant. Any thoughts about what cleaning compounds should be used before we get to the disinfection?
So when I think of cleaning, if you look at some of our some of the handouts that we have from the PACEP, a lot of it is just removal of anything that looks visibly soiled at the time. And so really it just has to do with trying to remove anything that's visible. You could probably, if you wanted to add some soap and water to it, I think that's fine. I don't think we go much beyond that in the cleaning realm.
Okay, great. So here's a question for Ashley about the clots. Do you need to use gloves with a clot product due to the skin irritation or due to potential for dermal absorption and toxicity?
It's really the skin irritation and the potential for long-term sensitization. So you may get away with it once or twice, and then the third time now you've got this terrible contact dermatitis. So that's really the reason, not for dermal absorption.
Another question was brought up about reactive airway syndrome, which was discussed, and any effective method to treat that in this setting.
I think I'll take that one because bleach certainly can lead to that. I think this is more going to be treated as regular asthma when these attacks occur. So you are going to use your bronchodilators and steroids during the attacks. Unfortunately, there's no way to once RADS is occurring, there's no way to prevent these attacks other than telling the patient to avoid these exposures that precipitate these attacks. So, but otherwise, it's similar to asthma treatment.
Thank you. Another question about the toxicity associated with the use of Lysol. Now, I know Lysol is kind of a brand name, and Lysol could be a variety of different chemicals. But any thoughts about Lysol spray and similar agents? Ashley, you want to handle that one?
Well, like I said, I mean, I agree. I mean, it can be a number of different agents. I mean, there are brand products that go across all, I think, practically all of the chemical constituents that we mentioned today. And I guess I would.
Yeah, it could be any of the.
Yeah, there's quats, there's alcohols, there's ammonia.
Peroxide,
so you have to really look at,
I would turn that question.
Brand, not a product.
Right.
Actually, I would flip that question. I know you looked at that a little bit in your preparations regarding the spraying. I think somebody they were asking about spraying to disinfect. What is that? Does that have any special impact, special effects, or concerns?
So, if you're using something that's a hand spray bottle product, you just need to make sure if you're trying to disinfect, that the whole area is equally, has equal contact and can get wet. So you can miss areas if you're spraying. If you're using, so there are things like foggers and hydrostatic sprayers, they spray indiscriminately and they're not targeting any certain area. Those devices that, as soon as somebody touches something, whatever you've disinfected is undone. So for most occasions, those are not really necessary. You just risk stirring more particles up into the air, more droplets up into the air with those that could be inhaled.
Yeah, and I just add to that a little that, the issue really does get to be what is the setting, right? So, I mean, extensive cleaning of every, molecule or every surface, touch or otherwise, is something that we've reserved nationally for things like mail facilities that were contaminated by anthrax spores, something like that. Whether you have something that's both very, very difficult to inactivate or kill, and where surface not touched but could have been landed upon, maybe a potential reservoir. That's completely different than looking to remove, some small number of viral particles from a doorknob. And so the idea of going to an extensive containment process to treat some room or some building or a school or something like that, it doesn't really make sense. And it does have all the potential that Ashley just mentioned for residual contact to a person, or inhaled products, which could then exacerbate asthma and all. So it doesn't make sense to the setting that we're usually talking about here.
And also, I wanted to just ask Ashley, there was a question about quats and the development of COPD at hospitals.
Yeah, so there's like maybe 1 or 2 studies that are retrospective questionnaires of nursing staff, and they are not quat specific. So they showed those who endorsed exposures to workplace disinfectants. So it was bleaches, alcohols, quats, all just lumped together, had as somewhere between a quarter to a third increased risk of COPD. It was not associated directly with quats. I think there are 2 studies that kind of showed similar effects. So there's some limitations, because I think if you just take disinfectants as a whole bucket, like most of us are, exposed to them at some point. So it's a little bit hard to tease out. So there is some thought that perhaps there's a risk, but it's not fully teased out at this point.
And I agree with that, Ashley. I think, this is a similar problem to translating animal research into human effects. And I think, one of the safe strategies is to just be precautionary. And, if there are safer products out there and you're able to use those, I think it's better to follow these kind of precautionary principles, especially with populations that are vulnerable, such as children, for example.
Here's a question for Dr. McKay about hydrogen peroxide potentially reacting with roughing or rust on a surface. Could you comment on that at all?
Well, yeah. There is the potential, since it's activated in a sense, or inactivated, depending on how you look at it. It does its chemical degradation in response to contact with transition metals. Then yes, it can interact with metal surfaces. There is a potential for that. That in terms of its problematic use in terms of deteriorating a surface, that seems to be mostly a problem at higher concentrations, and not with the marketed, especially the 1 or less than 1% disinfectant products.
Okay, and there's a question about the role of UV rays in the disinfection process. And I think, Dr. Kazzi, we're planning to feature that in an upcoming webinar at some point. Isn't that correct?
Yes, we hope to do that in the summer, hopefully.
Yeah, there's a number of kind of non-chemical approaches to disinfection, and we should definitely address that in a future webinar. Yes, I'd like to turn this back to some of the other speakers and Dr. Kazzi's moderator. Other questions? We only have about another 5 minutes or so max to get to.
There was someone mentioning droplets wouldn't simply be there on their own. And you're right, there's not like quat droplets floating all around this. When I was referring to masks could potentially block droplets, that I mean like while you're actively like spraying your spray bottle, or while you're actively stirring or diluting a product. So, you don't need a mask to like block quats 24/7. That's silliness.
Okay, great, thank you. If we could go back to the slides, I think we'll have Dr. McKay take us through the summary slide
Yeah, so certainly we're paying a whole lot more attention to disinfectants because of the pandemic, but as been mentioned by a bunch of people, it is still an issue even without the pandemic. Fomate transmission or contact transmission is possible for a number of infectious agents. It appears to be, it is certainly not the primary, and it is maybe not even a very important community-based means of transmission. But if you have people who are coughing, sneezing, and then moving that to an inanimate surface, will touch it and move that within the hour right to their face, that's the setting for transmission, and that's where you'd want to try and prevent that. In addition to the regulatory required stuff for the given areas we talked about in terms of businesses and childcare settings. So the best disinfectant will vary both with the setting and with those kind of regulatory requirements, but all of them require proper cleaning before chemical disinfection. Even hydrogen peroxide-based disinfectants, which are talked about as doing dual purpose cleaning and disinfection, the use instructions say clean with the product first and then disinfect with it again. So it's not like you get away from a two-step process with that. Education and things like this, a lot of the resources that we've mentioned and those that will be up on the website, they're very important because this is going to be an ongoing issue even after the epidemic is over. Our real concern is potential toxicity from repetitive use of some of these chemicals. And if you are in a setting where the combination of everything, frequency of use, number or lack of adequate ventilation, are prominent, then you probably want to go to a compound where those are not as much of a concern. And preventing those exposures, especially keeping things locked and up, not mixing things that are incompatible together, particularly things like acids and ammonia with bleach products, and diluting appropriately and not using concentrated products in the way that they're not intended. Those are still very important. I do apologize that we did not get to all of the questions. I know a number of the questions focused on other potential compounds or the use of other agents. As I just remember that for regulated areas that the EPA approved disinfectants are required. And we refer you to Dr. Weber's lecture that's on the website, which was a very nice review of the disinfectants as a group. And again, some of the process involved in choosing that, mostly in the healthcare facility, but some of the principles do still apply. And also the CDC's disinfectant document that's up on their website and is also referenced in our reference list for more information on some of those. And thank you very much.
Yeah, moreover, I think one of the best things coming out of this webinar today are all the questions. They really do provide a roadmap for what sorts of information is needed going forward as we discuss disinfectant strategies and understand their advantages and some of the pitfalls. So we are committed to getting this information out. We've already began to develop this FAQ section on our website with these questions, and we will take these questions in the queue that we did not get to back to develop some answers to and to provide this information going forward. So I'd like to thank the audience for attending today. We had over 800 people on the webinar, which is really amazing for this topic, and given all the competing educational opportunities on topics related to the COVID pandemic. Again, I'd like to thank the PACEP program and ATSDR for supporting this webinar. This, as mentioned at the outset, is the second in a series of probably about 6 webinars in disinfectants, and so you all get information about our future webinars. As we continue our COVID webinars on the medical and public health implications, we have 3 really important webinars coming up in the next month. Next Wednesday, we'll have a webinar on the long-term effects of COVID-19, otherwise sometimes known as the long hauler syndrome. And we'll have both a plenary presentation as well as a actually a physician who's been suffering from the long hauler syndrome for many months now, was recently featured in a JAMA article. That will be followed on March 10th, a very important presentation on vaccine distribution. We're in the crux of the midst of vaccine distribution to the world, and we have several experts that have studied this over a long period of time, and will present various different modeling approaches to efficient vaccine distribution. And then following that on March 17th, we'll have really a fascinating presentation about the impact of COVID on long-term care facilities, and looking at some of the ethical issues, particularly that have arisen during the pandemic. Next slide. So again, thank you very much, everyone, for attending today. Again, thanks to the panel and to the speakers. Our entire COVID webinar series review can be seen on this in this document, this prospectus, which you can find online. If you have any questions about this webinar series or any suggestions, please contact us at info@acmt.net. Thank you very much, and have a good day.